statements be made part of the hearing record if they are submitted to the clerk by 5 p.m. today or the close of the hearing, whichever comes first. Hearing no objection, so ordered. Without objection, the chair may also declare a recess subject to the call of the chair. Hearing no objection, so ordered. As described in the hearing notice, statements, documents, or motions must be submitted to the electronic repository at hnrcdocs@mail.house.gov. Additionally, please note that as with in-person meetings, members are responsible for their own microphones. As with our in-person meetings, members can be muted by staff only to avoid inadvertent background noise. Finally, members or witnesses experience technical problems should inform committee staff immediately. I will begin by recognizing myself for opening statement. Once again, good afternoon, or if you're out west, good morning. Welcome to our virtual legislative hearing. First, I would like to note a change in our subcommittee roster. Representative Lowenthal has switched out of this subcommittee so that our newly elected colleague, my nueva mexicana hermana, Representative Melanie Stansbury, can join. Welcome, Melanie. It's fitting that she joins us for this hearing as she both represents a couple of pueblos, but also has urban Indians in the city of Albuquerque as her constituents. We will miss Mr. Lowenthal, but I'm thrilled to have another strong New Mexican voice representing tribal communities on this subcommittee. As stated earlier, today's legislative hearing will cover two bills, H.R. 442, the Southeast Alaska Regional Health Consortium Land Transfer Act, sponsored by Ranking Member Don Young, and H.R. 3496, the Urban Indian Health Providers Facilities Improvement Act, sponsored by Representative Ruben Gallego. These bills focus on ensuring quality health care for American Indian and Alaska Native communities. As we begin to look beyond the COVID-19 pandemic, it's important to note that quality health care in the Indian Healthcare Service will remain a critical issue for this subcommittee. Our first bill, the Urban Indian Health Providers Facilities Improvement Act, would amend the Indian Healthcare Improvement Act to grant direct funding to urban Indian organizations for the renovation and maintenance of healthcare facilities. Currently, urban Indian organizations do not have access to facilities funding under the current IHS budget. This means there was no funding available for urban Indian organizations, facilities, maintenance and improvement, sanitation equipment, and other essential projects throughout the COVID-19 pandemic. Although Section 509 of the Indian Health Improvement Act permits the IHS to make funds available for urban Indian organizations, this is only available if the organization maintains accreditation standards of the Joint Commission, or TJC. This sounds simple, but in practice, it is a very different story, which we will hear about today. Currently, only one of the 41 urban Indian organizations across the country maintains TJC accreditation. Most urban Indian organizations hold accreditation through the Accreditation Associations for Ambulatory Healthcare, AAHC, or the Commission on Accreditation of Rehabilitation Facilities and Patient-Centered Medical Homes, all of which are reputable accreditations. H.R. 3496 fixes this problem by ensuring that urban Indian organizations receive the funding they need to construct, maintain, and renovate their facilities, whether they have TJC accreditation or not. Next, we will review the Southeast Alaska Regional Health Consortium Land Transfer Act, sponsored by Ranking Member Don Young. H.R. 443 will convey 10.87-acre parcel of land in Sitka, Alaska, currently owned by the Department of Health and Human Services, to the Southeast Alaska Regional Health Consortium. The Southeast Alaska Regional Health Consortium is one of the oldest and largest Native-run health organizations in the U.S. It delivers health care on behalf of the federal government through self-determination compacting, one of my favorite aspects of legislation. This legislation today will allow the consortium to begin construction and renovation activities on the medical facilities it operates on two parcels of land. With that, I look forward to hearing more about the bill from each sponsor and our witnesses, who I want to thank very much for being here today. Alaska, you with us? I would now like to recognize Ranking Member Don Young for his opening statement, as well as an opportunity to speak on behalf of his bill. Thank you, Ranking Member Young from Alaska.
Thank you, Madam Chair. I hope you can hear me, but thanks for having this hearing. I always worry about these things. I don't know whether people hear you or not, but I see my great friend, Mr. Ohalva, is doing a fine drawing right now, so you better be listening, Mr. Chairman.
I always listen. It's
All
my
right.
attention deficit disorder.
Anyway, Madam Chair, thanks for having this hearing, especially for HR 442. You explained it very well. This land is a transfer, or the bill is a transfer of land to the consortium that provides health care for my Alaska natives. I would like to introduce my witness today, Michael Douglas. He's the Senior Vice President and Chief Legal Counselor for the consortium. Michael's been with CERT for 9 years, which is a long time, and he's a Haida and an enrolled member of the Central Council Tlingit Haida Indian Tribes of Alaska. His family comes from Heidelberg, Alaska. The second part of our deal with him is he does a great job. CERT has done an outstanding job. This is a simple bill. We passed bills like this before, and I hope it'll be rapidly moved by you, Madam Chair, and the full committee to success, because it's needed for the health care for my people in Alaska. Your second bill, of course, 3496, is an urban Indian health organization, which I've supported all along. The bill would remove a provision requiring UIOs to use these funds to get specific accreditation. I think the bill is a good bill and should be moved too. And with that, Madam Chair, I'd like to look forward to my witnesses, your witnesses, and we'll get these things done as we should. Thank you again for having this hearing. So thank you, Madam Chair. I yield back.
Thank you so much, Representative Young. I do want to recognize that we do have the chair of the full committee with us today, Chairman Grijalva. Chairman Grijalva, would you like to make a statement?
No, other than to tell Mr. Young that I am paying attention, and more importantly, to say that these two bills and Mr. Gallego's bill brings an urgency to the point that you made at the beginning, that when 60+% of Indigenous persons and tribal members in this country are residing in urban areas and in non-reservation areas, non-tribal land areas, this Mr. Gallego's bill is particularly important as a follow-up to the COVID pandemic, and to the follow-up on the disparity with regard to the healthcare that Indigenous people receive. It's a really good piece of legislation, very timely, given all the other discussions that are going on right now in terms of reconciliation, etc. And Mr. Young expands the delivery of health services to Alaska Natives and American Indians in Alaska, and that is it is a good move to expand the availability of services. And both good pieces of legislation. Congratulations to you to bringing them up, and we'll pledge to both members, you and I, that we'll move these as rapidly as we can to make sure that they're part of the discussion going forward with any budget or future legislative packages. Thank you.
Thank you so much, Chair Grijalva. The chair now recognizes the gentleman from Arizona, Mr. Gallego, for a statement on his legislation.
Thank you, Madam Chair. I want to thank Chair Ledger Fernandez and Ranking Member Don Young for holding a hearing on my bill, the Urban Indian Health Providers Facilities Improvement Act. I also want to thank our witnesses for being here today. My bill, HR 3496, would allow urban Indian health providers to spend the money they already receive from Congress on projects most needed to improve patient care. Under an old, obsolete view of law, urban Indian organizations are effectively prohibited from using their funds on construction, renovation, and other infrastructure improvement projects, unless the project was undertaken exclusively to maintain an accreditation standard that is no longer in use by the vast majority of UIOs. The types of projects that have been delayed by and gone unfunded due to this provision include the construction of urgent care facilities in infectious disease areas, projects to expand primary care and urgent care patient capacity, ventilation system improvements, and upgrades to telehealth and electronic health record system. What's worse is that over 70% of UIOs report having infrastructure backlog in these areas. UIOs provide culturally competent care for the over 70% of American Indian and Alaska Natives who live in urban centers, many in low-income, medically underserved areas. Making sure UIOs use their limited resources on the projects they know will most benefit patients is how we ensure that these vulnerable populations receive the best care possible. That's why my bipartisan bill simply removes this obsolete provision of law and allows UIOs to spend their money where it will be most effective for patients. I look forward to hearing from our witnesses today, Ms. Sonia Tetnowski, about how this bill will pave the way for increased investment in urban Indian health infrastructure without Congress spending an additional dime. Thanks again to our witnesses for being here, and I yield back.
Thank you, Congressman Gallego. I'd like to now transition to our panel of witnesses for today. But before introductions, I'd like to encourage the witnesses to participate in the Witness Diversity Survey created by the Congressional Office of Diversity and Inclusion. Under our committee rules, oral statements are limited to 5 minutes, but you may submit a longer statement for the record if you choose, and I would note that we have received your written statements, and I thank you for that. When you begin, the on-screen timer will begin counting down. It will turn orange when you have 1 minute remaining. I recommend that both members and witnesses joining remotely lock the timer on their screen. When you go over the allotted time, I will gently ask you to please wrap up your statement. After your testimony is complete, please remember to mute yourself to avoid any inadvertent background noise. I will allow both of you to testify before we move to questions. The chair now recognizes Ms. Sonia Tetnowski, who is President-elect of the National Council of Urban Indian Health.
Chairwoman Fernandez, Ranking Member Young, and members of the House Natural Resources Subcommittee for Indigenous Peoples, thank you for the opportunity to testify today. I'm Sonia Tetnowski, an enrolled member of the Makah tribe and currently the President-elect of the National Council of Urban Indian Health, which represents 41 urban Indian organizations. UIOs provide high-quality, culturally competent care to more than 70% of American Indians and Alaska Natives that reside in urban areas. As the CEO of the Indian Health Center of Santa Clara Valley and a UIO that provides comprehensive health care to nearly 24,000 patients, representing 114 different tribes, I testify today in support of the Urban Indian Health Providers Facilities Improvement Act, H.R. 3496, which will expand the use of existing Indian Health Service resources to be spent where they are needed, specifically for necessary facilities maintenance and renovation. I applaud Representatives Gallego and Representative Bacon for introducing this bill that will fix an unnecessary barrier to care and allow UIOs to make critical updates to our facilities. Specifically, this bipartisan bill corrects an oversight in Section 509 of the Indian Healthcare Improvement Act that effectively prohibits us from using our IHS funding on infrastructure and facilities improvement projects unless the project is undertaken for accreditation by the Joint Commission. TJC is no longer the accreditation body that is used among the vast majority of UIOs. 40 of the 41 do not utilize TJC accreditation. For example, at IHC, we have accreditation by the Accreditation Association of Ambulatory Healthcare, AAAHC, for more than 20 years now. AAAHC is a nationally accepted accreditation body, which IHS promotes as an accreditation option for UIOs. However, our AAAHC accreditation effectively bars IHC from utilizing IHS funds for any facilities improvements because the statute only mentions TJC, which meant that we were unable to utilize the IHS funding to make potentially life-saving facilities upgrades such as our HVAC system because we were not accredited by TJC. In other words, a health facility could not use its funding from a health agency to make air purification changes while in a global pandemic of an airborne virus, solely because of the restrictions this bill seeks to fix. At IHC, we have been forced to grapple with difficult decisions between direct patient care and facilities investments to meet the critical infrastructure needs essential to continuing to provide high-quality care to our patients. This bill would remove unnecessary limitations to our funding, immediately allowing UIOs to use our IHS funding more effectively and efficiently. Inadequate facilities and safety issues are never something I nor any other UIO want impacting our care that we give to our patients. We need this legislative fix now. In addition, this essential fix has widespread support, including within Indian country. I would add, NCUI, the National Congress of American Indians, and the 29 other Indian organizations requested this change in an infrastructure needs letter to Congress. This bill also has extensive support among policymakers, with House Interior Appropriations, including the UIO facilities fix in fiscal year 22 appropriations bill and the President's FY22 budget. This support makes one thing clear. We must act now to pass this urgent bipartisan and no-cost legislation. We urge the members of this subcommittee to include this priority in your request to leadership for the next infrastructure package. In addition, we respectfully request a markup on the bill as soon as possible to allow the floor consideration. Finally, to demonstrate a strong showing of commitment to improving urban Indian health, we ask all members to co-sponsor HR 3496. Thank you again for your time today and for working with NCUI to ensure Native people can receive high quality care regardless of where they live. Thank you so much for your time today.
Thank you, Ms. Tetnowski, and thank you for your timely testimony on time. The chair would now like to recognize Mr. Michael Douglas, who is the Senior Vice President and Chief Legal Officer for the Southeast Alaska Regional Health Consortium. Thank you very much, Ranking Member Young, for your extended introduction of Mr. Douglas. Mr. Douglas, for 5 minutes.
Thank you. Good afternoon, Madam Chair, Ranking Member Young, and members of the committee. My name is Michael Douglas. I'm the Senior Vice President and Chief Legal Officer of Southeast Alaska Regional Health Consortium, or SEARCH, and a member of the Haida Indian Tribe enrolled to Central Council Tlingit Haida Indian Tribes of Alaska. I bring you the greetings of our board chair, Ms. Kimberly Strong of Klukwan, and our President and CEO, Charles Clement of the Metlakatla Indian Tribe. I am truly honored to appear before this committee to testify in support of the Southeast Alaska Regional Health Consortium Land Transfer Act, HR 442. In doing so, I'd like to thank our representative from Alaska, Congressman Don Young, for his unwavering support for Alaska Native communities and in particular, tribal healthcare providers in Alaska. SEARCH also greatly appreciates this committee's time and consideration of this bill. By way of background, SEARCH is an Alaska Native-run nonprofit tribal health organization. We're authorized by the resolutions of 15 federally recognized Alaska Native tribes to compact with the Indian Health Service and administer a comprehensive healthcare delivery system for the Tlingit, Haida, Tsimshian, and other Native peoples of Southeast Alaska. SEARCH was founded in 1975, and as mentioned in the introduction, is one of the oldest and largest Native-run health organizations in the country. We first contracted with the IHS in 1976 under the Indian Self-Determination and Education Assistance Act to take over management of the community health aid program, and have been compacted to assume operations of Sitka's Mount Edgecombe Hospital since 1986. Today, we've grown to provide essential healthcare services in 27 Southeast Alaska communities and counting, including the operation of critical access hospitals in Sitka and Wrangell. We have a service area covering just over 42,000 square miles of the Southeast Panhandle, most of which is only accessible by boat or plane. This bill today is critical to our efforts to redevelop and improve the Mount Edgecombe Medical Center campus in Sitka. The Mount Edgecombe Medical Center is a 25-bed critical access hospital through which we provide a full scope of healthcare services, including medical, dental, behavioral health, physical therapy, radiology, lab, pharmacy, labor and delivery, and surgical services. We also provide substance abuse treatment services, emergency medical services, health promotion, and traditional Native healing. However, the Mount Edgecombe Medical Center facility was constructed in 1943 by the War Department. And while historic, at 77 years old, the hospital is in poor condition and understandably can no longer meet the requirements of a modern healthcare system. So the need for HR 442 is simple. SEARCH has been working for some time to rejuvenate our Sitka campus, including plans to construct a replacement facility for the aging hospital, and we are deep in the process of finalizing our agreement with the Indian Health Service to move forward with our IHS joint venture construction program project. With that joint venture project, Search will modernize the MEMC campus with the construction of a new 207,000 square foot state-of-the-art healthcare facility, which expands our services while increasing access and availability of care for the patients we serve. HR 442 directs the Secretary of HHS to transfer to Search 2 remaining parcels of land within our campus, which are adjacent to the future hospital site and house our Community Health Services Administration building and the existing hospital. These 2 parcels of land are critical for our overall development of our campus plan under the joint venture project and will ultimately be used to support the new hospital once construction is complete. Our bill is nearly identical to prior legislation, the Southeast Alaska Regional Health Consortium Land Transfer Act of 2017, which is signed into law December of 2018, and similarly authorized warranty deed transfer well over 19 acres of IHS properties within the MEMC campus. To date, the IHS transferred the first 11 acres of that property to Search, which has been designated as our future hospital site. And we've now completed all the environmental assessments and surveys that are necessary to transfer the remaining parcels, as well as the parcels proposed under this bill. With this HR 442, the warranty deed transfer of the remaining properties will allow us to consolidate ownership of our campus, better position Search to obtain financing for the new hospital, and ultimately allow Search to repurpose these facilities to support the new hospital once construction is complete. So we're very excited to embark on this project, which will allow us to immediately improve patient care, demonstrate to our patients that Search remains committed to delivering the highest possible care for generations to come, and will provide much needed employment throughout the region. So in conclusion, Madam Chair, we ask for this committee's support of the bill so Search can begin to move forward with redeveloping our Mountain Edge Medical Center campus and constructing this critical replacement hospital. Thank you so much for the opportunity to testify today. How?
I thank you both for your testimony and for your excellent work providing services, needed health services to the Native American, the Alaskan community. I'd like to remind the members that Committee Rule 3D imposes a 5-minute limit on questions. The chair will now recognize members for any questions they may wish to ask the witnesses. I'll start by recognizing myself for 5 minutes. Ms. Tetnowski, your testimony states that urban Indian organizations, the renovation and maintenance projects could only use IHS funds if they meet a specific accreditation by the Joint Commission, which you also pointed out is not really the relevant accreditation that is used right now, and that instead most UIOs use other accreditation programs. Could you share some additional information on these accreditation programs and why they might be more useful for urban Indian organizations, and why we should feel completely confident that opening up the type of accreditation programs will continue to mean that the services you provide are safe, secure, and meeting the highest standards?
Thank you, Chairwoman. Yes, I agree with you. There really is no reason to keep this limitation on urban Indian organizations in statute. With our organizations receiving only 1% of the IHS annual budget, a restriction like this is extremely harmful to the 70% of American Indians and Alaska Natives who need our services. The Joint Commission was originally designed to serve hospitals. So many of the procedural evaluations done during this accreditation process are designed for hospital settings, where we're ambulatory care outpatient facilities. It's really not the best assessment of our ability to serve our patients.
Thank you. Mr. Douglas, I truly appreciate the success that you have had serving your community using the 638 Compacting Authority and the use of joint venture. When I was an attorney, we used both of those, and we saw incredible success, great growth, and the ability of the compacting tribes to serve the community, to make it very culturally relevant and appropriate to the needs of that particular community. Can you describe to us whether it's more urgent now more than ever to modernize and expand the services you're providing with the additional land transfer? Why is it more important now more than ever, given the situation where we're coming out of the pandemic?
Right. Thank you, Madam Chair. I think that one of the issues that we've continually faced with the Managed Care Medical Center is simply the age of the building. It was constructed, as I mentioned, over 77 years ago. And so we're really hindered in our ability to redesign our health programs and our delivery of care by the physical structure of that building. There are challenges with keeping things updated, like the air handling system, elevators, and things of that nature. And so by constructing a new facility and being able to redevelop the existing facility to support that, we're going to be better positioned to deliver healthcare in a much more modern environment and not really hindered by the physical structure of this 77-plus-year-old building.
Thank you. We did have a hearing earlier this year about the needs for new IHS facilities, and as you noted, the age of those facilities and the importance of replacing them, upgrading. And as I understand it, you have everything in place and you're ready to go, but you're waiting for this land transfer. Is that correct?
That's correct. We're waiting for the land transfer, and we are very close to finalizing our joint venture program agreement with the Indian Health Service. But we've been working on the planning for the new facility and the campus redevelopment for several years now. So as soon as those things get signed and things begin to move forward, we are essentially ready to go.
Thank you very much. I will now yield back the remainder of my time, and the chair would like to recognize Ranking Member Young.
Thank you, Madam Chair, and again, thank you for having this hearing. And Michael, your testimony, my bill, by the way, transfers 11 acres with the warranty deed. Can you describe the importance of receiving the land by warranty deed rather than by quick claim deed?
Thank you. Yes. So the distinction, at least from Search's perspective, is that we'll have significantly more flexibility with how we utilize the property, how we're able to redevelop it to support the future hospital once constructed. And it also really better positions us to obtain financing to construct the new hospital. As you know, the joint venture construction program requires the tribal organization to finance the new construction for the facility, and in turn, the IHS requests appropriation to staff it for a given period of years once construction is complete. So we'll simply be better positioned once we go out to obtain that financing and begin construction.
The warranty deed is a lot better for you than the quick claim deed, then you can get the job done.
It is.
Okay. And the second question I have for you is, we transferred some land you mentioned in your testimony, I think last year or the year before. What have you done with that land, and how would this new transfer fit with that project?
Yes, that's correct. So as of now, 3 of the parcels approved for transfer in the prior legislation have effectively been deeded to Search. A few others remain, and provided that this bill moves forward, will be incorporated into the warranty deed at that time. Some of them had certain environmental assessments that needed to be completed. Some of them were subject to state and federal historic preservation laws that needed to be accommodated. And so as of now, we're simply using the bulk of those 3 that have been transferred so far to design essentially the site for the new hospital location. And so at this point in time, I believe we've begun some clearing, but are waiting for the IHS joint venture program agreement to be finalized before we fully move forward with the project.
Thank you, and I want to continue to congratulate you, as the chairman has mentioned. I think Search has done a great job. You expanded. I remember when you first started, that was a little rough time. Certain people didn't support you. They do now, which is a very good thing. And this land transfer should take place. I often think we ought to do the whole thing at one time instead of going back and back, because I don't want anybody else on your campus. So that's something else might happen. And Madam Chair, for your information, this used to be a military establishment. It's about 75 years old. It's wore out, but one of the good things that came out of World War II is we did build some facilities we have been able to use afterwards. So with that, Madam Chair, I yield back my balance of my time.
Thank you very much. The chair would now like to recognize the gentleman from Arizona, Mr. Gallego.
Thank you, Madam Chair, and thank you for again for letting my bill be heard. My first question is for Ms. Tetnowski. In a previous hearing, IHS testified that it did not know why the restriction that HR 3496 removed still exists in the Indian Healthcare Improvement Act. From your perspective, is there any legitimate reason to keep this limitation on the books?
Thank you, Representative Gallego. No, there's no reason to keep this limitation on urban Indian organizations in statute. With our organization receiving only 1% of the IHS annual budget, a restriction like this is extremely harmful to the 70% American Indians and Alaska Natives we serve at our programs.
Thank you. So would passing this bill have any impact at all on urban Indian health organizations' ability to gain, maintain, or lose accreditation under existing standards?
This bill is separate from our ability to gain, maintain, or lose accreditation. The archaic provisions was designed to help UIOs, but instead has hurt us by hamstringing IHS from allowing us to use any federal funds we receive from them for any infrastructure improvements. In fact, the accreditation in question is not even one utilized by UIOs. It is largely for hospitals, and most UIOs instead maintain a triple AHC like ours, which is designated for small ambulatory clinics.
And lastly, can you describe the range of infrastructure improvements to urban Indian health facilities that are currently not eligible for funding under this current restriction? Is it just brick and mortar infrastructure or other system improvements, potential system improvements?
IHS has conveyed to our area offices that anything remotely tied to upgrading any parts of our facilities would be deemed ineligible. This has included updating our HVAC systems for safe ventilation as recommended through the health inspection for patient safety, installing indoor vestibules in the northwest area when it's cold to ensure that our patients do not have to wait outside in the weather, and repaving a parking lot to set up an outdoor testing and vaccination site, and even little things like putting up partitions or installing hand sanitizing stations was not allowed during this process.
Thank you, Ms. Tatowski. And this is why I introduced this bill, because there are so many things that we could be doing and so many things that our UIOs should be doing right now, especially to really get ready or overcome COVID, or even many that are still going through COVID in many areas. And this costs the federal government it doesn't cost the federal government any money to lift this restriction. So thank you, and I yield back my time.
Thank you. The chair will now recognize the gentleman from Montana, Representative Rosendale.
Thank you so much, Madam Chair. Montana is home to 7 reservations, and so the health and well-being of Indian country is extremely important to me and all the people across our state. Montana is also home to several urban health organizations, which would be impacted by the Urban Indian Health Providers Facilities Improvement Act. Unfortunately, over the last 18 months, we've seen Indian country hit disproportionately hard by the COVID-19. And speaking to administration officials in the Indian Health Service, as well as the Bureau of Indian Affairs in past hearings, they've indicated to me that among an array of reasons, poor infrastructure was one of the reasons that those increases occurred. Mr. Tetnowski, what impact, if any, do you believe the infrastructure investments enabled by the Urban Indian Health Providers Facilities Improvement Act would have on the ability of Indian country to effectively respond to future viral outbreaks?
Thank you, Representative Rosendale. As an urban Indian health program in San Jose, we were considered one of the hot spots at the very beginning of the pandemic. As you know, our numbers continue to rise, and with that rise became continued concerns. Without the ability to utilize the resources that was being provided, and I appreciate the work that IHS did and Congress did to ensure that we had resources coming to our facilities, we weren't able to optimize those resources to fix the facilities in order for us to be able to respond quickly and adequately to those rising number of cases in our areas. And in doing so, we had to make critical decisions to provide services outside of our facilities to ensure that safety, which also put other places at risk, right? When you're bringing patients with COVID or testing to other locations to ensure that they're receiving the care that they need or the testing that they need, and ensuring that we're complying with CDC guidelines, it really put a hamper on what we could do within our time frame.
So could you describe some of the particular kinds of investments that this legislation would enable that you believe should be prioritized in order to mitigate those additional risks?
Infrastructure is the key component to that response. HVAC systems, as I mentioned before, was one of the critical areas. We had to install air purifiers in each individual treatment room, which was also very costly. Because we couldn't upgrade our whole system, we had to resort to these smaller pinpointed responses. This would allow us to also make modifications to do things like store our ultra cold freezers. We need to have a particular space. It has to be separated from other areas. It has to have a certain amount of feet around it so that it doesn't incur any additional air quality issues when you open and close that particular type of freezer. Those things were not possible under this past pandemic, which could be resolved in the next one. Also having clean rooms, areas where we can have space that is specifically clean and has the ability to be ventilated on a regular basis if there is another pandemic that would allow us to do those types of renovations.
Very good. So I believe that while it's clear improvements need to be made to many of these facilities, it's also important that we are good stewards of the taxpayers' funds because they're not unlimited either. How will we be able to ensure that the funds are prioritized for the facilities and areas in the greatest need or renovations of improvements?
You will see through many pieces of information that the National Council of Urban Indian Health has provided. We provided priority lists of things that we need to upgrade our facilities to be as responsive as possible and to be efficient. One of the things, because we only receive 1% of the IHS annual budget, we're very efficient and we're able to utilize our dollars in the most effective way to provide that comfort back to the taxpayers.
Excellent. Thank you so much. And Madam Chair, with 13 seconds left, I will yield back.
Thank you for your generosity on the time, Mr. Rosendale. The chair would now like to recognize our gentleman from Florida, Representative Soto.
Thank you, Madam Chair, for hosting this really important hearing. You know, Florida has been hard hit by COVID-19. In fact, we're seeing surges even now, sadly, among the young vaccinated. And our Seminole tribe and Miccosukee tribes were also hard hit over the last year or so. We lost several members of the tribes, including a decorated Vietnam War veteran last year, Don Osceola, a pillar of their community, as born a Seminole and became a member of the Miccosukee tribe. He passed away last year, among other folks we lost. And the Seminole tribe was approved for disaster declaration last year, which helped out with this. The state of emergency definitely helped with funding for vaccines, mental health, and other issues. And as many of you may know, they're both a urban and rural tribe, areas such as Hollywood, but also areas around Lake Okeechobee in rural areas of South Florida. And so everything from broadband and telehealth to improving Indian health services is absolutely critical to being able to ensure health equity for our tribes like other Americans across this nation. And that's where HR 3496 by Representative Ruben Gallego will make a real difference as we're expanding funding authority for renovating, for constructing and expanding certain facilities in the Indian health services arena. Ms. Tetnowski, thank you for being here. Your testimony briefly mentions how one urban Indian organization was denied clearance for a new HVAC system during the COVID-19 pandemic because of the existing funding restrictions. Obviously, having some urban Indian tribes in Florida, this is particularly relevant for our area. Can you detail other ways this funding restriction affected other UIOs throughout the pandemic?
Sure. Thank you, Representative Soto. And I'm sorry to hear of the loss of the veteran in the Seminole community. I am also a veteran, so I understand that loss to community and the value that they bring to their community. The continued work that urban Indian programs do and the impact that would have is on infrastructure, things like telehealth, upgrading our access to intranet. As you know, in rural communities in particular, they tend to be the last mile of an electrical grid and probably the last 10 miles of a internet system. So there typically is spotty internet. So although telehealth became available, it was not always optimized because they didn't have that quality service like you and I are enjoying right now. Without the investment in infrastructure, this will continue to go on. And as primary care continues to go to this virtual platform, it's really important that they have access to that infrastructure and the ability to improve their telehealth services and provide access to their patients in that way. Also construction, minor construction as well as major construction will improve those services, and including HVAC systems and other air quality systems. One of the things that is often not recognized is the work that's done in dentistry. So no matter what you're doing, especially in a pandemic, that potential exposure of a dentist to a patient who has COVID or has had COVID or may not recognize that they have COVID, the risk is pretty high to our providers. So investment in their air quality and their ventilation system and their filtration systems is really critical as well.
I'm glad you mentioned dentistry because healthy teeth is absolutely critical for nutrition, particularly for young people, and we want to make sure we have reasonable access to dentists, and they need the right equipment. As we look to build back better and pass the American Jobs Plan, it's absolutely critical that we include tribal communities, both in healthcare, economic development, infrastructure, and other needs. So thank you for your testimony, and Madam Chair, I yield back.
Thank you.
Thank you. The chair would now like to recognize the gentleman from Oregon, Mr. Bess.
Sorry about that
Mr.
delay.
Benz?
I'm here.
Okay.
Thank you, Madam Chair. So just a couple of questions. The first has to do with the nature of the deed, and I'm as an attorney, I was just curious about the reference to the environmental contamination element of the deed, and I was looking at page 3 of HR 442, and this question I think is best suited for Mr. Douglas. But I was just curious, in the last line on page 3, it says, as defined in any federal or state of Alaska law. I was just curious if this bill is intended to prohibit or head off liability for contamination that might arise under state law as opposed to federal. Because I wonder how this federal legislation would achieve that. And perhaps I'm misreading the bill.
Thank you for the question, Congressman. I'm not certain that that's the intent. I think that this has been federal property since the construction of the facility. And one of the reasons why we did not include these two parcels in the prior legislation is we simply didn't know the extent of any potential contamination. There were previous parcels that were transferred that had, for instance, officers' quarters with fuel pipes running between them that we coordinated with the Indian Health Service to clean up. I think with these two particular parcels, now that we've had opportunity to do all the environmental assessments, I think that there's very little of concern on these two properties, but I'm not certain that intent of that language was to indemnify the parties under state law.
No, actually, and this is, I think, a moot question. I just, as an attorney who dealt with this kind of stuff all the time, I have not seen it approached in quite this fashion, but I believe the federal government remains responsible in any event, so I don't think it matters, but it was I thought that a bit odd, the way it was phrased, but I only raised that issue because as a lawyer, I just can't help myself. But now moving on to the question, I think best put to Mr. or Sonia, there we go. And it has to do with the assertion that we must pass this urgent and no-cost legislative fix. And I just wanted some explanation of why this was a no-cost fix. And by that, I'm referring to, of course, HR 3496.
Thank you, Congressman Pence. It's a no-cost fix because it has a 0 score, and it is not. There's no financial dollars attached to this particular bill. It's specifically around correcting legislation to ensure that we're able to utilize the funds we're already receiving through the Indian Health Service. So no additional dollars are attached to this particular piece of legislation.
Right. If I may follow up on that, I kind of took it to mean that, but it seems like if the money is there, either it's stacking up in an unused heap, or it's being taken from someone else who had been using it for something else. Which might it be?
No, it would actually be for us to reprioritize the dollars that we're currently receiving to apply them towards infrastructure needs. So although I have shared in my testimony that we've had to prioritize our patient care versus facility upgrades during this process, we would now be able to, moving forward, utilize the dollars that we're receiving to make those upgrades necessary for patient protection.
And that does a nice job of answering my question. Thank you for that. And my last question, I was the hospital's lawyer in my small town for 18 years, and we did use the accreditation group that you haven't been using. We used the Joint Commission, and it was a great big deal. And I was just curious why you don't use the Joint Commission, but instead use the Accreditation Association of Ambulatory Care.
The Joint Commission was designed for hospitals. And so most of the procedures that it's assessing are specific to hospital operations, whereas AAAHC is designed specifically for ambulatory care and the operations for outpatient, which is the service we provide.
Right. Thank you so much. Great answers. Yield back, Madam Chair.
Thank you. The chair would now like to recognize the gentlewoman from Minnesota, Ms. McCullum.
Thank you, Madam Chair. This has been very important to hear firsthand about what's going on. And I want to thank you so much for hosting this and for giving me an opportunity to learn more. And that's, everything's been kind of answered as we've been going along. So thank you.
Thank you. The chair would now recognize the gentlewoman from New Mexico, Miss Stansberry. Representative Stansberry.
Good morning. Yes, thank you, Madam Chair, and thank you to everyone for your wonderful welcome this morning. I'm so honored to be able to serve on this committee. It's such a critical committee for the state of New Mexico, and I look forward to working in partnership with our sovereign pueblos and tribes across the state and with our tribes and tribal organizations across the country. I am grateful to have the opportunity to ask a question this morning about this important bill, which Chairman Gallego has brought forward. Of course, urban Indian health organizations are so vital to our communities around the country, including in my own district in Albuquerque, New Mexico. And so, Ms. Tednowski, I wonder if you could elaborate a bit more on the importance of urban Indian organizations and what the kinds of services look like on the ground as they're being delivered to people in our communities, and why they often experience so many difficulties in gaining parity within the IHS system.
Thank you so much for that question. Urban Indian health programs have historically only received 1% or less of the IHS budget. And so we only receive about $640 plus per patient per year, which compared to other health systems where it can be up to $4,000 per patient per year. This obviously is initial inequity. But the things that we provide on the ground for that small amount of money is providing direct patient care, medical, dental, and behavioral health. Many of us provide other wellness services. All of us provide additional cultural and culturally specific services where we are utilizing our culture within our programs to ensure our American Indian community is receiving that culturally competent care, including things like traditional services such as talking circles, sweats. We provide other cultural trainings and prevention programs, workforce development to create our next generation of leaders, which I always love doing, and really providing that direct patient care. So many of our programs have a variety of clinics throughout our service territory. Myself, I have 4. But there are 77 facilities throughout the U.S. providing these comprehensive services and providing that direct care to the 70% of American Indians that live in our rural or in our urban areas.
Thank you so much. I'm so glad that you brought in that description of the sort of integrative care and how the care incorporates often in many of these organizations and these clinics, the cultural elements and the other aspects of well-being. And I think we can all agree here that there is nothing more important than the overall well-being and health of our communities, and that these organizations are small but mighty, but important institutions across all of the communities that they serve. And so I very much look forward to supporting this bill and advocating strongly for it. And with that, Madam Chairwoman, I yield back. Thank you.
Thank you very much. The chair would now like to recognize the chair of the full committee, the gentleman from Arizona, Chairman Grijalva.
Thank you, Madam Chair. And first of all, I think the sponsors of the legislation and certainly the witnesses have made the strongest case for the need for these pieces of legislation and the urgency to see how we can expedite that. And but I don't have any other questions. I think that the flexibility that Mr. Gallego's legislation is asking for Indian Center, Indian Health Service providers in urban areas that are non-affiliated with the tribal provision of health delivery from the Indian Health Services. I think that it's been, both on the population issue, but also on what we just went through and with the pandemic and going through, as Mr. Gallegos correctly said, we're not done with that by any means. And so I think that flexibility, the discussion that this committee has had time and time again about the need for investment in health in Indian country, in particular healthcare. I think they all fit together. And the case for the regional health consortium and the expansion into that property is pretty obvious. I don't have any other questions other than to say that if the case needed to be made, it's been made very well. I don't think it needed to be made, but thank you.
Thank you very much, Chair, and I completely agree with you that our witnesses as well as our sponsors made a very strong case for both pieces of this legislation, especially in this moment. I do note that the IHS and our compacted tribes have done an excellent job in responding and getting the vaccinations out. I applaud you on that, encourage you to continue that up. I spoke with one of the members of one of the tribes in New Mexico, and they had two people left who hadn't been vaccinated. So we're looking forward to having the same kind of response rates throughout Indian country. I'd like to thank our witnesses and the members for their insightful questions. As I stated before, the members of the committee may have some additional questions for the witnesses, and we'll ask you to respond to those in writing. Under Committee Rule 3.0, members of the committee must submit witness questions within 3 business days following the hearing, and the hearing record will be open for 10 business days for those responses. If there is no further business, without objection, the subcommittee stands adjourned. Much appreciated. Goodbye.